it's still breaking.
The voice is better, but it's still breaking.
Okay, so Dr. Saida, can you start or
Sometimes if you stop the video camera, maybe
okay.
sometimes that help.
Yeah, okay. Assalamu alaikum. My name is Hajer Ali. I'm gonna moderate the meeting today in behalf of the great team. How is it now?
Better.
Good?
Good.
Okay. Okay, thank you. Yeah, Assalamu alaikum. Today, January 13, I'm gonna moderate the meeting for the great group. Welcome everyone. Okay. We will gonna present three topics. The first topic, four topics actually. The first topic will be about telehealth. I will gonna present it, and the second one about resident and well-being, and the third one about oral manifestation of squamous cell carcinoma. We're gonna present it by Dr. Manhel, and the fourth one with Dr. Suhaila. We're gonna present. She will gonna speak about her program. Thank you. Let us start.
Not today. Next week. So
Oh,
last July. Yes, not today.
Okay, I'm so sorry.
It's okay.
Okay, let us start. Are you able to see the screen?
Yes.
Okay, telehealth. Telehealth is the use of information and communication technology to deliver health care at distance. Implementation of care of older adults has lagged national sample of adults 50 to 80 years old in 2019. Only 4% have a real-time telehealth visit in the prior years. Each telehealth modality has been shown to be feasible and acceptable to older adults in a variety of settings. Let us see what are the telehealth modalities. We have different forms of telehealth. We can categorize it as asynchronous and synchronous. Asynchronous means exchange and review of health information outside real-time patient interaction. There is no real-time interaction. For example, secure messaging and between the patient and the provider, like the patient portals, and it can be between clinicians also. Another form is electronic consultation, also is another form of asynchronous. Synchronous one is a real-time interaction between the patient and clinician, for example, live video visit and telephone calls. There is remote patient monitoring, remote data collection, giving feedback to the patient, maybe synchronous or asynchronous. Telehealth also can be used in education for education purposes, and also between will be real-time interaction between clinician, like the ECHO education program. Let us speak about asynchronous. It is also known as store and forward transmission. It is a method where doctors receive and store information, patient information digitally for later review. So as we said, there is no real time interaction. Example, secure messaging between patient and clinician, secure messaging among interprofessional team members, and electronic consultation. Let us see what is in each one of them. Secure messaging between patient and clinician, like a patient portal. As we know, in every clinic there is electronic medical records. So this type of telehealth have positive impact on patient satisfaction and retention, and it is easy to access. Regarding the portals, or the adults with low or high health literacy may benefit from specific training in using patient portal. Caregivers who manage health information may need specific outreach and training. Yes, we need to ask the patient if he can use the portal. We have to educate him. We have to educate the caregiver and train them how to use the portals. Once enrolled, the individual with higher health literacy may be more likely to find secure messaging useful. Also, there is the other use is secure messaging among interprofessional team members. This method identified as a core quality indicator for home-based primary care and palliative care practices. It facilitates time communication among complex patients and more cohesive care planning. When implementing this method in senior living communities, it is associated with fewer emergency department visits for ambulatory care and sensitive conditions. Electronic consultation, also type of asynchronous telehealth. Okay, it can be between, it affects the primary provider. It allows specialty input on a specific problem, but may increase the workload for the provider. Regarding the patient perspective, the patient will benefit. The patient will have faster access to care and no need to travel. But in another side, there is inability to discuss the treatment plan and ask the specialist more questions. Regarding the specialist, from specialist perspective, electronic consultation, the specialist can give a brief input on more efficiently, but for complex questions, the time spent may not be adequately compensated, and complex care plans may be difficult for a primary clinician to implement. For synchronized telehealth, it is a form of remote, real-time patient-doctor communication using voice and video channels. Type of synchronous telehealth may be between clinician to clinician, maybe by telephone encounters or by video encounters. So there is real-time interaction. Okay, between clinician and clinician, there is different types of like programs, the education programs. We have Scan Echo, which is a specialty care access network, ECHO, or extension for community health outcomes. Here there is regular teleconferences between training programs, based training programs, where primary care clinician or rural provider who present cases to specialists via video. The specialist recommend management plan and provide didactic instruction for the primary care physician. Echo care transition. This one help hospital providers communicate with interprofessional clinician at skilled nursing facilities, which may help reduce length of stay and rehospitalization rate and costs. This is example of telehealth in between clinicians. Another form is virtual geriatrics, formerly known as geriatric case conference series. This one also, it's the hub model in which urban geriatric centers provide consultation for rural veterans and their primary care clinician. Okay, there is a social media also. We further expand the reach of geriatric education efforts. Example, by streaming geriatric grant rounds through social media. The webinars also, especially during COVID-19 pandemic, it helped in education the patients or the people about the vaccination. Okay, telephone encounters. Telephone encounters are more universally available than video, and many important diagnostic and therapeutic tasks can be accomplished by telephone. For example, long ago, before COVID-19, they mainly do mental health assessment and psychotherapy through telephone, follow-up of the patient on psychotropic medication, also assessment of health risk and physical activity, increase physical activity and promoting exercise through text message. Improving pain and disability in older adults, support smoking cessation, screening for cognitive impairment also can be done by telephone. Okay. Okay, we have selected cognitive screening tools for telephone use. For example, telephone interview of cognitive status and modified telephone interview of cognitive status, telephone assessment mental. All of these are programs we can install in telephone and assess the patient with it, like screening tools. Now, let us talk about synchronous telehealth. Synchronous can be also about video encounters. Let us talk about video encounters. It is a rapidly evolving area of care. Regulatory requirements were relaxed to provide access during the COVID-19 pandemics. The benefit of video encounters, the ability to perform certain parts of physical examination using observation or patient participation. It also, there is expansion of geriatric expertise to patients who might not be able to come to the clinic, but there is a limitation for the use. Technical literacy. Need to operate video technology. The patient have to be able to deal with technology. Challenge of establishing rapport with patient in person, not like remote visit, building rapport with the patient. Okay, this is important to prepare for a video visit with an older adult. You have to verify that the patient has high-speed internet, a device with webcam, ability to access and operate the video communication program being used to monitor if available. One for conducting the video visit and one for simultaneously accessing the health record. Verify all participants' contact information and test the setup before the visit. Arrange for caregiver or medical interpreter as needed to be available either on site or by phone or video. Patient and provider should each be in a private, quiet setting. To start, at the start of the video visit, verify the patient physical location, the presence of anyone else with the patient, and obtain verbal consent. Obtain contact information for technology support, for troubleshooting, and for local emergency services, just in case something happens. Anticipate challenges and mitigation strategies, for example, hearing impairment. Elderly, most of the time, have hearing impairment. You have to be sure that there is headphones, there is closed captioning if available. Vision impairment, if the elderly have eyeglasses or adaptive device or program, example, magnifying software, use a plain background and high contrast, example, black or white for any text. Cognitive impairment, caregiver assistance, simplified video device program. Yeah, most of them also they have cognition impairment, so the caregiver assistant will be helpful. The son or daughter. Yeah, the connectivity speed and the internet connection also. Just in case there is some issue, you have to talk to through the phone or change the video call. Okay, we have 5M, like a targeted assessment area for geriatric patient. We can introduce this or integrate this in video call also, adapting the geriatric 5M for an age-friendly video visit. The 5M, number one, what matters? Geriatric patients have different complaints. We have to be specific and ask what matters most for them. Example as assessment during video visit, advanced care planning, caregiver burden, observe the home. All of this can be done during video visit. Medication, view medication and polypharmacy medication. We have to assess for cognition. Maybe there is acute delirium or delirium screening, cognitive screening. Mobility, ask the patient, perform chair stand and observe gait. All of this can be done through video conference. Multiple complexity, assess patient priorities when addressing multiple visits, conduct priority assessment based on history and observation. Okay, remote, this is another form of telehealth, is remote patient monitoring. It has been used on a large scale within the VA or veteran hospital for chronic disease management, primarily in older adults. Factors that affect utility include patient and clinician engagement, integration of data into the medical record, clear flow, workflow, and timelines of clinical response. For example, monitoring of blood pressure, weight, temperature. Also, in patient like patient with heart failure, you can ask them to monitor to put the weight every day, and then you can tell them to restrict the sodium or increase the dose of diuretics, and so on. Reimbursement policy implication for geriatric telehealth. Before COVID-19, it was a little bit restricted. Traditional Medicare provided very limited coverage for telehealth. Although Medicare Advantage plans and ACO offer reimbursement with fewer geographic and site restriction. There was a restriction before COVID-19, but after that, it was through the CARES Act, COVID-19 brought rapid, although temporary, relaxation with reimbursement criteria. Okay, we have ethical and legal consideration for geriatric telehealth, privacy and HIPAA. For example, before COVID-19, even the program you do, like the video conference or something, have to be approved by HIPAA, but this restriction is now not like the previous before COVID-19. There is no HIPAA violation will enforce when non-public facing platform are used in good faith. So now we can use Zoom meeting or Microsoft or anything else, or FaceTime. Licensure, an state medical licensure compact was introduced in 2017, with more than half of states participating, allowing eligible physicians to apply for licensure in multiple states at the same time. Okay, control substance prescription, also on supervision of trainees. Supervision of trainees, yeah, now we can use telehealth also in clinical rounds, or all of this can be through telemedicine, through video, through, yeah, since COVID-19, it become more open. Okay, equitable access to telehealth. Approximately 10% of United States adults remain offline. Being offline is linked with older age, less education, low income, Black and Latinx ethnicity, rural residents, and disability. Telehealth also require access to an appropriate device and comfort with technology, or at least a supportive person to help. Okay, this is estimates. Okay, let's summarize that. Okay, enhancing access to video telehealth for older adults at the point of care. Internet access. This is limit the use of telehealth, digital literacy, device accessibility, and video visit accessibility. So in video visit accessibility, use simple, user-friendly platform arranged for support person, as we said. In a summary, the COVID-19 public health crisis and result temporary relaxation in privacy, payment, and legal restriction on telehealth have catalyzed a profound shift towards synchronous telehealth use for older adults. Telehealth modality are often categorized as synchronous, store and forward, asynchronous, a real time between the patient and provider at the same time, remote patient monitoring, which may include both asynchronous data collection and real-time feedback or interaction. Modification must be considered to accommodate patients with hearing, vision, cognitive impairment, as we said. Clinicians should exercise judgment when deciding whether a telehealth modality is appropriate and achieve a standard of care that is comparable or superior to in-person care for a given situation. Likewise, clinicians should use caution when adapting and interpreting geriatric assessment tools that have not been validated for remote admission. Okay, this is the end of the presentation. Anyone have question before we start the questions?
Thank you so much. Thank you so much, Dr. Hajer, for this great presentation. And it's very concise to the point and explaining things. So yeah, during the pandemic, COVID, the government relaxed some of the limitation of the use of telemedicine. So in the past, it was used with some limitation. Some physicians were afraid or not at the point where they want to use, but we were unable to do that because of many things. One of them is payment. So there was a difference in payment if you see the patient in the clinic or in like a virtual method. So thank you so much, Dr. Hajer. And any questions? If no questions or comments, then we can move to the next topic.
Dr. Sarra, are you here? Sarra?
Yes, I'm here. I sent you the PowerPoint. You can find in your email in the last one. It is ready as a PowerPoint. I just could you hear me?
Yeah, I can hear you. Yes.
Yeah.
I see it now. Dr. Sarra, I couldn't open it in PowerPoint.
Yeah. The last one is PowerPoint, Hajer. I send it as PowerPoint just right now. If you can find it. It's okay if you couldn't find it.
Yeah, I can share it as PDF. It's okay.
Okay, yeah, you can do that.
Okay, go ahead.
Okay, give me a second, it's not in yet. Assalamu alaikum. Assalamu alaikum, Dr. Nadir. Assalamu alaikum. Hi, everyone. My name is Sarra Gabralla. I'm presenting stress on medical residents, the effect of burnout in medical professionals. Medical residents are an integral part of the healthcare system, but they often experience high level of stress and burnout. This presentation will discuss the importance of well-being in medical residents, as well as strategies for achieving this goal. First, I will start with the definition of the burnout. So burnout is a syndrome of emotional exhaustion, depersonalization, and reduced personal accomplishment. Burnout can lead to negative repercussions for individuals experiencing it, as well as the people for whom care is provided and the community at large. So it's not affecting just the residents or just the individual, it affects also the people around that, or the people, the person take care of them, like patients, of course. So high levels of burnout among residents are associated with perceived suboptimal patient care and decreased effectiveness and empathy toward patients. We discuss here the impact of stress and burnout in medical residents. So generally, studies show that residents' well-being overall was lower than population average. BGY1 residents, I can't see well here. Let me, yeah. Can you slide it a little bit toward the left side, Hajer? If you can. No, to the left. The other way. Yeah, I couldn't see well. Oh. Couldn't see well in here. This is all. Can you a little bit to the left side of the screen, Hajer, if you can? Yes, a little bit to the left. Yes. So generally, studies show that residents' well-being overall was lower than the population average. BGY1 resident had lower rates of overall well-being in comparison to BGY2 and BGY3 residents. That study showed that. And female residents had the lowest probabilities of scoring above the study population mean for well-being. They were also more likely to report frequent feeling of sadness or depression. So here is the diagram showing the consequence of job burnout. So it affects both sides, personal and professional. We talk first about the personal. It can lead to broken relationship, alcohol and substance use, depression, and suicide. On professional sides, it decreased quality of care and increased medical error, and also decreased patient satisfactions and decreased productivities and professional effort. So at the end, it leads to physician turnover. Yeah. This is just like statistical studies showing that the burnout by the specialty. So this study showing that emergency medicine physician and critical care physician at the top, so they have higher burnout rate, and then at the bottom is the public health and preventing medicine, showing that they have least burnout rate. So those, the emergency medicine and critical care carry out high level of burnout rate, yeah, according to these studies. And I believe this study is done 2022. Yeah, it's a little bit old now. Okay. So here are some strategies to promote well-being. And these slides show that some programs have care about their residents and they take care of the burnout. And this is, so it is important for the program to promote residents' well-being by providing a healthy environment that gives the residents a sense of control and autonomy, and achievement of goals, opportunities for learning, positive feedback, and positive quality relationship. So adding stress management training to the medical education curriculum could help the residents deal more stressful with the stress of training. Regular monthly relates to promote a positive culture among colleges. So this is the program can take care of all these points. So can decrease the residents burnout. So I have another slides, but at the end of the presentation, how the residents themselves care of burnout. Here, the ACGME requirement for the program. First, enhance meaning in work, promotions of progressive autonomy, increase administrative support, attention to work intensity and compression, excluder of residents to receive medical care during scheduled work, education of residents to identify symptoms and signs of burnout, depressions, and suicidality, preventions of depression, suicide, self-screening, like 24/7 mental health resources. So program should provide the residents 24/7 mental health resources. And then continuous adherence to 80-hour workload, including no more than 16-hour shift for BGY once. Continuous 1 day off in 7 with no greater than Q3 calls. And residents can stay past end of the shift to continuous to care for single patients. And this is according to the residents themselves. They ask to be allowed to stay past end of the shift to continuous care of a single patient. So here we can see what driving the problem and then what it lead to. So workload and job demand, meaning in work, efficiency and resources, organizational culture and values, social support and community at work, life integrity, and control and flexibilities. So more optimum of this will lead to engagement, and less optimum of this will lead to burnout. So as I said, more optimum of all the 6 or 7 I mentioned, need to engagement on work and good environment, and less of optimum will lead to, of course, of physician or residents burnout. Yes. Here is some strategies to promote well-being, and this is residents can do it themselves to decrease the level of burnout. First, for example, mindfulness, and is defined as awareness that arises from paying attention to the present moment, non-judgmentally. Example, meditations, yoga, and walking in nature. You can get like regular exercise for 30 minutes per day, getting at least 7 to 8 hours of sleep per night. Of course, family support and social activities have a great role to decrease burnout in residents. And this advice, not just for residents, I guess, these strategies help all of us to decrease the level of stress in overall. So I think we are about to end this presentation. Thank you, Dr. Nadir. Thank you very much for listening to me today, and thank you for the opportunities to share this knowledge with you. And I listed some resources at the end of this. If you can, yes, this is the resources I use. And also Dr. Nadir has a great like research or paper on this website you can refer to. Yeah, it has a lot of information about the burnout and stress. It is very helpful if you can look and read through. It is concise and very like good done. Thank you so much.
Thank you so much, Dr. Sarra, for a great presentation. Excellent work. Any questions or in addition, any comments, suggestions? So it's a hot topic in the last few years. The residents were evaluated for this because they want them to learn, get the training, provide the high or the highest healthcare plans for their patients. So it's important to let them feel okay and participate in the plan of care. Thank you so much. We can move on to
Thank you, Dr. Sarra. Yeah, it is very important topic. The next topic will be presented by Dr. Manhel. It is about the oral squamous cell carcinoma.
Assalamu alaikum. Let me start sharing my screen. Please let me know if you
yeah, we can
what
see.
is it? You can see it now? So yeah, Assalamu alaikum, Dr. Nadir. Assalamu alaikum, everybody. I will talk about the most common type of the oral cancer, this oral squamous cell carcinoma. The oral squamous cell carcinoma represents a significant global health challenge, accounting for a considerable proportion of head and neck malignancies. Progressing silently, it demands early recognition to improve prognosis. I'll talk about the definition and prevalence of oral squamous cell carcinoma, the pervasive health issues. Oral squamous cell carcinoma, the most prevalent malignant tumor of the oral cavity, affects millions globally. It exhibits a high mortality rate, reflecting its aggressiveness and late-stage discovery. It is more prevalent in men and older adults, but recently cases in younger population are rising. When we talk to about the risk factors for developing oral squamous cell carcinoma, tobacco use and alcohol consumption will come first. Tobacco, like smoking, chewing tobacco, are drastically increase the oral squamous cell carcinoma risk, and heavy alcohol use synergizes with tobacco to elevate the cancer risk. Also, studies show that is like several cases of oral squamous cell carcinoma are linked to human papillomavirus infections. So within the oral cavity, there is more sites that are like favorite sites for the squamous cell carcinoma. Tongue, especially the lateral borders of the tongue, are the primary sites for oral squamous cell carcinoma initiation. Also, floor of the mouth, which is known the poorest prognosis, or the for poorer prognosis, which it is the second common of oral squamous cell carcinoma, which has the poorer prognosis. Also, we have the lower lip, which is more exposed to carcinogens, which is also one of the common location of the oral squamous cell carcinoma of the oral cavity. Also, yeah. For the sign and symptoms, so persistent sores, any non-healing ulcers, or sores in the oral cavity persist for more than 2 weeks should be questionable. If there's also pain or numbness, that means there is nerve involvement, like altered sensation or prolonged pain may indicate nerve involvement. There's also obstruction or discomfort with the swallowing. So this is also a common sign of squamous cell carcinoma of the oral cavity. About the importance of early detection and diagnosis, that is really will help with like better outcomes. Early detection of oral squamous cell carcinoma improve the survival rate. Also, it reduced the morbidity because like early stage cancer may need less invasive treatments, which is reducing the long-term effects. Besides that, it will be like cost effective, like earlier diagnosis often result in lower healthcare costs. Diagnostic methods for oral squamous cell carcinoma. First, we start with visual examination. So a healthcare provider can notice the oral tissue abnormalities. With palpation, the tactile examination helps detect masses or nodules in the oral cavity. Also, the toluidine blue stain, it's a dye that's used to highlight the suspicious lesion during examination. The clinical examination starts with interview. We collect and extract information from the patient histories, and then we'll do the clinical examination to detect the early sign of oral squamous cell carcinoma. And then the next will be the biopsy and histopathological analysis. Biopsies will provide tissue samples for microscopic confirmation of oral squamous cell carcinoma, and also it's help with examining the cellular makeup of tumor, clarifies aggressiveness and cancer grades. And imaging techniques that's used to diagnose the squamous cell carcinoma of the oral cavity. The X-ray is useful for examining bone involvement and change. CT scan provides detailed cross-sectional images of the oral structures, and MRI highlights soft tissue contrast and determine tumor extent. For staging and grading oral squamous cell carcinoma, we use a TNM system with T, as we know, it stands for tumor dimension, and N for lymph nodes involvement, and M is for metastasis, or determine the presence of distant cancer spread. When it comes to the treatment options for oral squamous cell carcinoma, surgery is the first option. where it's a primary treatment often involves tumor removal and affected lymph nodes. Next is the radiotherapy, high energy radiation targeted destroys lingering cancer cells. Chemotherapy, chemicals used to adjunct to surgery or to palliate symptoms in advanced cases. So in some advanced cases, like when surgery is impossible, we just put patient on chemotherapy. Surgery as a primary treatment modality, so do like complete removal of the tumor and margin of healthy tissue to ensure clear boundaries. And reconstructive surgery, it's a post-excision reconstructive effort aim to restore the function and aesthetics. Radiation therapy and its role in treatment. Radiation therapy can target a specific area with minimal damage to nerve tissue. Often follows surgery to eliminate residual cancer cell and reduce recurrence. Chemotherapy and targeted therapy in advanced cases. Chemotherapy treats cancer systemically, reaching widespread areas. Targeted therapies may also focus on a specific molecular change seen on oral squamous cell carcinoma. There's also immunotherapy, and it has some benefits. Immunotherapy harness and amplify the body natural defense mechanism, and some patients may experience improved outcome and survival rate. That. Multidisciplinary approach to treatment. So team collaboration is necessary for that. Combining expert knowledge from various disciplines lead to comprehensive care, and treatment are tailored based on a specific stage and nature of the disease. Rehabilitation and support care after treatment. First, the functional recovery. Therapies focus on speech, swallowing, and dietary adjustments. Emotional support, psychological care, and support group assist emotional healing post-treatment. And physical reconditioning efforts to restore physical strength and endurance are essential for quality of life. And the most important thing is regular follow-up and surveillance, continuing monitoring, regular checkup help catch recurrences or new cancers promptly, and also lifestyle adjustment. Ongoing advice on healthful practice can decrease the future risk. Thank you so much, and let me know if you have any question.
Thank you. Thank you, Dr. Manhel. Great presentation. Any questions?
Thank you, Dr. Manhel, for also excellent, great presentation. This is very important, and we need to know about this topic. Thank you so much for sharing. Great, great work.
It's my pleasure. Thank you.
Any questions for Dr. Manhel or any of the presenters, or any comments? You can share with us your experience if you have any encounter. I know some of you here in the US, but some may have some experience back home or some in the Gulf or UK.
Another, you are muted.
Thanks. Any updates as far as projects or any questions regarding the fellowship or suggestions, comments, questions?
Yes, thank you very much, everybody, for presenting these topics. I'm actually a new applicant, and this is my first meeting, so I would appreciate if one of you or the team leaders or one of the members like to explain how to join the teams, where can I find the link to the app, and how do you start looking for a topic and all that. Thank you so much.
You're welcome. Welcome, first of all, thank you for joining the program. So here the app, if you go to this website here, research subject.glideapp.io. I'm going to share this with you guys also in the chat. So you can log in using your email that you provided when you applied for the program. When you come into the app, it will have some information up there, but we will have the connection or the link for the Zoom meeting. If you want to see the schedule for next coming, it will be here. You can click on this, or you can have the information for the login for the ID, and that can be changed. So if you use the app, it will be updated. Here's the upcoming scheduled meetings in the future. And in the past, we had also a couple of meetings, so you can review some of the previous meetings if you are interested in certain topics. If you scroll down, we have some videos, some related to the meetings. So the last week meeting or the week before, we have some Zoom recorded meetings. We have also other videos as far as skills that you can obtain, like how to record video, how to present, how to use Google Slides, or if you are applying for residency, some of them might be related to interview skills, and so you can go to see all, and you can filter this out. If you click on the menu here, you will have the interested group and things to do, but you will have the fellows, that's the seniors. In the past, we have some join us a year or more ago, and then the juniors who joined us less than a year. We have in this group, here you can find some of the team leaders. This can be updated as we have some leaders may join residency or fellowship, so they may not be available. So they will add it to new leaders for the team. So in the WhatsApp group, you will be updated as far as who will be leading that team. So if you go here, you can locate your name, for example, whatever, and it will list some here. So so that we have another here, and so forth. There are other features, so we want you to learn about how to apply to conferences. So we have AGS, for example, American Geriatric Society or the American Medical Association, and they have some opening of opportunities for presentation. So we look at their previous abstracts that were presented and some of the winners poster or abstract in these conferences. There are a lot of other conferences that we participate in. We have a list of projects, but you can create your own, or you can bring a new idea for a project, and we can work on that. We have teaching slides. That's the topic that we talk about. Like, for example, some of the fellows may work on certain topics. So we already have geriatric slides made by the American Geriatric Society. Some other information here you can find as well. So this is a brief introduction, how to use the app, and there are more features. So in general, we divide the newcomers into levels. So people might have some experience, so early trainer in research. So you might have some experience during medical school or after medical school, but you are not there yet. Some may have a greater experience, so they can fulfill all the knowledge that they need or the skills that they need doing the research, but they did not do that by themselves. So they participate in other research projects, like small parts. So you have the knowledge of the skills, but you are not the master, or you cannot start from beginning to the end by yourself. And then the last category is the one who knows much about research. So they've been working with projects, they know how to start, how to ask a question, how to create the team, divide the task, and complete the project until it's accepted or presented somewhere in a conference or as a paper. And they have this under their belt, as I say. So they know, so they have advanced level. So entry level or early, mid, and then late or experience. So you can find yourself where in this category. If you look at the app again, share the screen. So if you go to curriculum is here, this is where we were talking about early research experience, middle, and late. Then if you want an objective or what exactly we want you to know, these are the things that we want you to know or we want you to cover during this time while you're here. So we want you to know the basics of the ethics of and principles of doing research, starting from getting an idea, research question, you select a topic and you identify the area, see if this question was answered. If not, how can you, if it's answered, how can you modify your question to get more new knowledge? So you need to learn how to look at the literature and find out what's available there and what's not done, what we call the gap, knowledge gap or research gap. When you do that, then you can build on that. So we want to know how you design your study, and there are different methods, and how you select your sample, how you apply the other concepts, and you go over the details of how you start from zero until you finish the project. Sometimes we work in teams, so you don't have to know all, but we expect you to know some part of this as you go along. Hopefully by the end of the program, we will have many of these. So we want you develop and grow from this area to this area. If you are here, we want you to move to late experience or where you will have opportunity to flourish or sharpen your skills. If you are here, we expect you to teach the other two groups or category so that they can come and join you on this level. This is what the team approach is. So in the team, you might have people who knows everything, and you might have people on your level just entry. And so we expect the project leader may identify the task and then divide that between you in the team. If you see the task is too big, so you ask for help. If you think the task is too small, you have time, you can collaborate and do more than one task. So this is how we build the teamwork and the project assessment plan, and then implementation of this plan. The program itself, we have teams. So each team will have few members there. They will have the team leader. So the team leader will just organize, and they have their own other items. For example, today, the team leader from today's team, she is busy doing, let's say, exams or family or some, so she was not able to attend, but she will assign some of the team member to run the meeting. So Dr. Hajer stepped in, and thank you, Dr. Hajer, for doing that. So she is moderating the Zoom meeting for today. Team leader also can identify who will be presenting. So we want to have fair opportunity for everyone to participate, present, and teach us something. It's going to be good for you to have the skill of presentation. So in this group, it's okay to present and see if you can improve, if there is room for improvement as far as presentation, looking as a topic, creating slides and so forth. So the team leader will make sure everyone have somewhere participating and engaged. Some of you might have other things in life, so we expect you to participate as much as you can, but if things are happening that some of you might prepare for step 3, or some of you might have kids sick or family things on the side, so and you're not available. So the team leader, we expect you to notify them that you are not available because of so and so, and the team leader will not assign tasks for you during whatever period you want to be off or unavailable. So this is basically how the team will work as far as presenting during this weekly meeting. As far as the project, we will have each project designed or built on a specific idea. So the idea can come from you or any one of the fellows here. When you bring the idea, the research question, you can be the project leader for that idea. So we will expect you to develop a team. So you will express or open the floor for fellows who are interested in the idea or the topic, and then they can join you. When they join, you can then start to develop the method of your idea. So I'm going to research dementia in older adults in nursing homes during COVID between 2020 and 2023. In this group, I want to assess 10, for example. So you have a very solid question. You will have the team. So the team will have some members who will look at the literature. So we'll see how many topics in this are there. If there is a gap, that's a good thing. And then you will identify who in the group will do the first part, the introduction part of the background. So some people might look at the literature as far as getting references so that you can build your theory or topic as far as a background. Some might carry on with the methods. Some might work on the conclusion and the final analysis. And some might be working on submitting that either in a format of abstract to a conference. So these fellows will look at the conference that meet your question or the project. In my case, maybe we can apply to AMDA or the AGS, the American Geriatric Society. So we look at this and see what the teams or the requirement or what they are focusing on, and if we are matching that team. So if we do, then we will start working on the draft or the abstract. So members of the team will work on the abstract and writing the draft, and hopefully by the deadline we can meet some of the requirement and we can submit on time to the conference. If it's a paper or manuscript, so some of the fellows will start working on writing while others are collecting some of the references or collecting the data, analyzing the data. Hopefully, you will find a good match as far as the journal. And then when you're done with the draft or the abstract or the manuscript, we can submit it to the journal. This in general how we divide the work as far as a team built on project or idea research project. You can participate in as many projects as you have time available. You can learn more when you are participating more, but we expect when you submit to conferences, the team composed of 10 people or less, because when you apply when you submit the abstract, some of these conferences, they have limitation as far as how many authors in the abstract when you submit the abstract. So the first time we had close to 16 fellows, and all they want to do the same project. So when we submitted the abstract, we have limitation as far as maybe 8 or 9 spots for the authors. So the rest, they couldn't participate. So this is why from the start, we want you to have a team of 10 or less if you are thinking of writing an abstract. If you are writing a paper, I don't think there is limitation. It depends on the topic, the interest of people, and what the journal will say. And we have other parts. So we have webinars. In the past, we have 4 webinars done, and we have mobile app development. So also we have 3 applications that were submitted and published in Google Play Store. So for this, you can create your own team and work with people who are have the technical skills to build the app and then work on that as team. So we want you to participate in part in that process. Some of the fellows may work on developing the details. Some might work on the presentation as far as the website or requirement, and then some may go for the marketing or assessment and refining the app, so testing the app. So you can play a part in this team of this process. So app development is another area where people can work on. We have medical graduates from medical school. We have dental graduates who are in the US who wants to pursue dental career here. So we have 2. We have one from physical therapy, and we are expanding in the future. We may have some other members from other disciplines, for example, nursing or other part of the laboratory or any medical provider in the clinical aspects. So it's in general summary of what we are doing.
Thank you so much. Thank you very much.
You're welcome. So go ahead. Dr. Mafaz is here. Go ahead.
Hi, everyone. Good evening, and thank you very much for the informative presentation today. I don't have an update, but I have a suggestion for the program, if I may share that.
Yes.
Yes, so I have recently read about something called the brother sibling, the big sibling and younger sibling, which is when a senior is assigned to 1 or 2 juniors. So by this meaning, it's that the senior will answer all the questions regarding the telegeriatric program, for example, to the juniors, and they're easily accessible for the juniors when they're very curious about the new program that they just joined in. And it also provides this mean of an access between the juniors and the seniors, where they can have a balanced form of working together in projects rather than just the juniors together and the seniors together. So that's just one suggestion that I wanted to share.
Excellent. Thank you so much for sharing, Dr. Pass.
Thank you.
Yeah. So if someone can share the link for the WhatsApp group, the general in the chat, Dr. Ali was asking if he can be added to the general WhatsApp group.
I can share it now, yes.
Sounds good. And we have 2 new teams that were created. So I'd suggest if some of the seniors here or in the future may be interested in leading a team, maybe you can let me know so that I can assign you to one of the teams, the new teams, so that they can help. That would be great. So we are in need for 2 volunteers from the seniors. If not, anyone from the juniors can step up and would like to join as a team leader. The team leaders from the seniors, they can help you whenever you have any questions, and they can guide you. As Dr. Mufaz mentioned, they are there to work with everyone, so it's a teamwork. Any other updates or questions or comments from the seniors or the juniors or newcomers?
Hi, Dr. Nader. I just want to say thank you. Actually, thank you for everything that you are guiding us for these benefits, researches and information. And so I'm just I want to add that what I just I'm just starting with the Dr. Rayyan and Dr. Mufaz, the researching about the COVID. And when I start, it's my first time, but when I start, Dr. Rayyan, she showed us, and Dr. Mufaz, she's helping me how to, start working on this program. So when I just want to add the information to the Excel sheet, which was my first time, and when I saw those small, small, cells, so I'm just said, oh, how this information could fit. So I just go back to the app, and then I open the videos about the Excel sheet, and I found it so informative. So this is what I want to say, for those who are new, just all the information is here in this app, and you can benefit from it. Just take time. Watching these videos, it's very helpful. So you will know more, and you will start, working, effectively and helping the others for the research. And I really appreciate Dr. Mufaz and Dr. Rayyan, and you, Dr. Nader, as well. I really appreciate your help and the opportunity that you gave to us. Thank you very much.
You're welcome. Thank you for sharing your experience and steps that you did. Thank you so much for sharing that. The seniors also, Dr. Haifa and the seniors, they played a part of a role in your development. So thank you for sharing. Dr. Nawad, go ahead.
Hi, everyone. I hope everyone is okay. I think before 6 or 5 months, maybe, I have made a Loom video for people who are joining to this group as a new follow. So You can watch that video to help you how to navigate through the app, what's the objective of this Telegeriatric Research Fellowship, and how to access to your team leader, team member, and how to navigate through the app. Maybe Dr. Nadia will share that video. You can watch that video and have an idea of like how to access the papers which are published in this group, what are the team leaders' name, the color of the team members, and at the same time, how to access this app and what to do with the app, how to attend the meeting. So it will be a good, like maybe mock-up of 5 or 6 minute introduction to this app. It will be helpful just to kind of go through the app for people who recently joined this program. Thank you.
Thank you so much, Dr. Nawat. And for those, I'm gonna just share with you. So if you go there, you will have some videos here. So this will have all the list of videos from the beginning of the program. And if you click see all, you will have all programs. But Dr. Nawat was asking about the one that he made. So it's supposed to be somewhere here, I think. I'm not sure what the name in production maybe. So you can locate the searching the videos. For example, Excel sheet, how you want to do something using Excel. So there are some tutorials. If you go down, how to create a bar, for example. Google Sheet is another one. We have some videos that show you how to index match or some other tools, VLOOKUP or some advanced ways of using Excel. So these are some of them. Google Sheet, for example, you can look at some of the Google Sheet also tools or how we can use it. Residency preparation, for example, this is how you apply for like a RAS application. But we have our own meeting, and then some of the videos will have how to answer questions, behavior questions, and so forth. So this is a list of more the videos, and you can category. Then you can see it's going to be divided by categories and so forth. If you want to see the recent 3 videos will be listed here. If you want to go by specific categories, presentation, interviews, residency, research questions, statistics, Excel, for example, you can have some of these. It will list some of the videos as well here. Not necessarily all of them, but some might be useful. We have grand rounds at Sparrow. That will be on Tuesdays every other day, noon time, Eastern time. You can join this also. Or on Fridays in the morning, we have neurological, MSU neurology department. They have their grand round, and sometimes they have cases, so you can also attend some of them. I want to share with you some other website. So we have this website. I'm going to add it to the chat. So basically, this is where we keep our achievements or what we did so far. So we have the app development. We have 3 mobile applications that these are on Google Play. We have many abstracts, more than 40. We have different papers published. We participated in more than 24 or 5 conferences so far, and we have think, about 10 journals for webinars. So you can go to this website. So what I suggest, if you are new, you want to do some work, you can look at these abstracts and you can try to convert some of them to paper, and that can be done. So if you want to reach out to one of the seniors, maybe they can guide you or help you identify. So you can build a team about, let's say, we want to look at this, so you want to convert this abstract into a paper. So we have the abstract already accepted, presented in this conference. If you look at the PDF, it will have the basics of what the abstract is about. So your job is to further investigate the literature and see if there is any new data available, new studies similar to the topic. And then you can work on the expanding the background, methods that were used in this abstract, and some discussion parts. So you just try to expand on what's written here, and it's going to be a paper or a manuscript. Then we can send that manuscript. Usually you will change the title to something else, but you can identify a journal and then submit it to that journal. And hopefully it will be accepted. And if it's accepted, then all the team members will be able to list that in their publications and so forth. So there are a lot of abstracts out there. Any one of them can be converted into a paper. If you are working on certain things, you have the time, you can create the team, and then you can work on that. If you have new ideas, we will be happy to help you navigate and get that done as a project. Speaking about that, I think we have the Alzheimer Association. They are open now for some abstract submission until the end of the month. So we have a couple of weeks to submit. And we have also a PAN conference. Also, they are interested. So they opened the window for abstract submission. So they are accepting abstracts. So we can work on getting this done. These are two examples. If you look at other conferences, they may be also available, or deadlines are in the coming months. So you might have some time to work on submitting to neurology, for example, or cardiology conferences if you are interested in these areas. So let us know.
Indeed, Dr. Nader.
Yes, correct, Dr. Hajer.
Thank you. Anyone, any project update?
So I'd like to share with you some of the fellows here were accepted to a program in Colorado. And I think one of them is here. But next week we will talk about the details of the program. So it's in Colorado. Sohail and Sulaka will both of them present the idea about how you, if you are in the area in Colorado, they have a program where they help international medical graduates so that they can learn the skills and be prepared and ready for residency. and hopefully it's going to be easier to get into a residency program. The program is called CO, or Colorado WIP, COIP, and so they will tell us more next week. I know there are other states like Washington State, they can offer some of the residents. So you need to be in the state for at least 1 year, I think. If you have a green card or resident citizenship, if you have some experience overseas in the like medical experience after medical school, and if you are residing there for 1 year or more, and then it's easier for you to get into a training program where you will, it's like residency. You will be under one of the physicians there. And if you spend the first year, then it's going to be easier to continue in the medical field. Some other programs like fellowship, they also can accept fellows in your shoes, but they need green card or citizenship. They need step 3, and maybe they need some experience, 1 or more years of experience overseas. So we have some fellows in this program. They worked, one of them worked in England, for example, and she applied for a nephrology fellowship, and she was accepted. Others were applied to geriatric fellowship, and they were accepted, and I think ID fellowship also. So there are plenty of programs there. These are opportunities or alternative. If you go through the residency, that's well and good, but if you are struggling, maybe that's another option that you can think about. So during the preparation for this, we have a topic about using Excel sheet, for example, for analysis. So I'm going to just share with you how we can go over that, just the basics. So I'm going to share, say, so we can go to, if you want to create a new sheet in Google Sheet, so you type sheets.new and you hit enter, and it will create a new sheet for you. And you need to have an account with Google, for example. So you can name the sheet anything. So I'm gonna demonstration, for example. And here you will have the first column. Usually we will use it for ID, for example, the patient ID, and then you can add more information about the patient. So the age of the patient, the gender of the patient, and for example, height, weight, and you can calculate the BMI, for example. So most of the studies, if you look at them when they present it in New England Journal, for example, they will have table number 1 for the population or the sample that they used. So I'm gonna use you as my sample. So today we have about how many fellows now? 40 something fellows. So if I want from you all to answer this question, I want you to give me your age group from, I'm gonna go by 10, so from 10 to 20, 20 to 30, and 30 to 40, something like that. So this will be the group range. So maybe some 40 plus or 40, I don't see. But let's see, this is the age group. So I'm gonna send you, I'm just pretending, I'm gonna send you a survey where you will hit one of these categories. So some of you might be here, some of you might be here, some of you might be here. So when you hit that group, and it's gonna populate in this area. So the first person will be in this group, second person may be here, third person might be the same category, fourth person might be the same category, then fifth person, and then sixth person will be this. So this is my age group in this sample that we are talking about, like the fellows in this program. Most of them in their 20s or there's between 20 and 30s, if that's the samples that I tested for today, for example. So when the first person hit the gender, maybe she was a female, and second person was a male, and then female. All of them, the rest are female. So these are the gender. So when you hit the submit button, it will come as your gender you selected. Here it's gonna ask you what's your height. Maybe some of you might be 6'3", maybe someone tall, maybe someone is just 60 in inches, for example, and then 59, and then one is 65. The last one maybe 63 or 2. So this is the height that you mention in your survey when I get the answers. The weight, most of you in your 20s, 26 or maybe 29, something like that, and 30, 4, something like that. So this is the weight that I got from you guys. So how do I design the questionnaire so that I can get this answer? So the questionnaire design will be, first question will be, what's your age group? And here it's gonna be selection from a drop down menu. And then second question will be your gender, and it's gonna be either female or male. And third question, what's your height? And what's your weight? For example. So this is gonna be a number, this is gonna be a number. Yeah, this is how you design your questionnaire. So the person will click a list and then submit, and then click from these options and then add a number. And this questionnaire will come as data in this sheet, if that makes sense so far. So in Excel or in Google Sheet, you have a way to calculate things around. So I'm gonna use a very simple calculation. So from the weight and the height, I can get the BMI, for example. To do that, I need to figure out the formula for BMI. So I'm gonna go to Google. What is the formula for BMI calculation? So pound, inches square to kilogram square. And in Excel sheet. So this is basically, this is a formula that I want to go here. So if you click on equal sign and then you put some information here, it will calculate that. So I'm gonna just put it on the top there so that I know what's the equation that I'm using, okay? So here, I'm gonna change the weight with the weight, which is this column here. Just say E2. this is the cell E, and then the row 2. And the height will be the D and 2 here. D2. And you press enter. And it has a feature of auto fill. So if you like that feature, you click enter and it will calculate the rest of the results. But I'm gonna do it manually. So I'm gonna just express. So I'm gonna just copy this and then paste it here. Or if you drag this dot, you can get that applied to all the rows here. So this is how you do the calculation. So you get the weight, you divide it by the height and square 2 or something like that, 2 over 2. This is the calculation. You can also have a way of collecting the information about how many female, how many male in this sample. So what I'm gonna do is I'm gonna use the same method like an equation. So the first thing, I'm gonna change this into numbers. So if it's F, it's number 1. If it's M, it's number 0, for example. So I'm gonna say if C2 equal M, then it's 0. If it's F, then it's 1. So, and this time I'm gonna use the feature autofill. And as you can see, female equal 1, male equal 0, 3 females equal 1. So this is gender into 1 or 0, according to female male, if that makes sense so far. So you can use some formula here. It's kind of an advanced way of collecting data or converting data, but in other statistical program, this can be done using just the mouse. So you can convert some letters or categories into some numbers here, just for calculation later on. And I'm going to show you this in a minute. And we can do the same for this categories. So if it's this category, I'm going to put 1. If it's this category, I'm going to go 2, this category 3, this category 4, something like that. So if I do the calculation, it's going to be 1, here it's going to be 2, and here it's going to be 2, here's going to be 3, and here's going to be 4, something like that. So this is category of the age. And this will help me identify how many in this category using the numbers instead of using this format for the calculations might be difficult. So to do the calculation, I'm gonna count how many females here, and then how many males, and how many is the total. So I'm gonna do the total first. I'm gonna see how many females and how many males. So the total will be the sum of these categories or this list, and sorry. Sum will be total of this. So it's going to be 6. So here. So 6 people answer the question. And then the female, I'm going to just sum the total of 1. So 1, 2, 3, 4. Can I say sum of this list? And because the males are 0, then this will be 4. And this will be this minus this. So the total number minus the female will give me the total number of males. If you are following me so far, this is how you can do the calculation for a sample that you are collecting information about. And most of the time, when you see the paper in this journal, let's say the PMG or the New England Journal of Medicine or Nature, they talk about the sample, and the first table will be like this: our sample size, n equal, and in our sample now, we have 6 people answer this question or questionnaire. Out of this, you will have the gender, and then they will say we have females, and they will say 4 out of 6 female. So you will find something like that. Sometimes they may describe it in percentage. So they do the n, how many females, and then the percentage. So to do the percentage, we're gonna do equal this divided by this multiplied by 100. So 66.6. And sometimes you can see it written in this format. So out of the 6 sample people in this population or this sample, 4 of them is female, and this is equal to about 66.6% of the sample. How about the age group? So age, mostly, so the average age will be, what is age? So if the average age between, it's gonna be in the 20s. So average age is between 20 and 30. And most of the time they will have it in years, for example. So the age group in this sample, mostly, or the average is in the 30, between 30, 20 to 30, something like that. How about the BMI? So I think we need to divide by 100. Like that. No, 5 by 100. So maybe 5,000. Yeah. So we can get the average for this. So the first BMI is 31, second one 23, third one 35, maybe something like that. So how to get the average for BMI? So to do that, we can say average, and then I can give them this. So the average is 31.5. So BMI average 31.5, something like that. So this will be your table 1 in the paper when you read it. So they will give you an idea of the sample, what the size of the sample, and what the sample composed of, male, female, what the age. Sometimes they ask about smoker, non-smoker. Sometimes they are asking about marital status, married, not married, divorce, something like that. So you will have a table where they will give you more information. They call it the demographic part of the sample that they are using. So you can look at that and then look at your patient population. So I'm a geriatrician. This sample will not represent my patients. So my patients mostly in their 80s, 90s. So this sample does not apply to me. If they find anything in their studies using this sample, I cannot use it because my population is totally different from this sample, if that makes sense. If you are a pediatrician, you work with kids, average age is 10, 12, teenager. This also might not be a useful information for you. So this is how you look at the paper, look at the first table, so look at the sample, the size, the age, the whatever demographic information that you can get from that paper, from that table. And then you can say, oh, this paper represents my patient population. Then I can read further, I can study and get more information about that. If it doesn't apply to you, then you don't spend time on this, if that makes sense. So I'm gonna stop here and see if you have any questions or anything to add. Any comments or questions? So I'm gonna ask you now, do you remember where was that video you submitted, or did you upload it to the app? Because I'm trying to see if we can put it in the first page for the newcomers or the new fellows.
Are you talking to me, Hajer?
And Dr. Naud.
Oh, okay, yeah, okay.
Yeah, I know Dr. Naud created a video where he went over the app.
Yes, I did create a video using the Loom app. I will try to search it from my account and I will try to attach it to the WhatsApp group.
All right, that would be great. And if you can send me a copy,
Okay.
if
sure.
you can download it, or if you can upload it to a YouTube, that might be, or maybe just give me a link so that I can add it to the app here as well. Thank you.
Thank you.
Appreciate it. So we have one volunteer to lead one of the new teams. I'm gonna ask for another volunteer to lead the other team. That would be great if you can let me know the new team. Any other questions, any other comments, any other suggestions, updates? If you want to share anything, the floor is yours.
So what are the types of the studies that you do? Are they usually systematic reviews or meta-analysis, or?
We have all different formats. So some of the fellows work on systematic reviews, but in the past we presented some case presentation and some other types of presentations as well. So if you look at the website that we shared, TGF, and I share again with the chair. So this one is where you have mostly most of the abstract and maybe papers submitted. Application mobile app. So if you, let's say you are practicing in the Saudi Arabia and you have an interesting case, then you can share with us. You can create a team. You can work on getting this formatted in the abstract format and then submit it as a case presentation. If you are interested in education or teaching, maybe you can share some methods. So you create a team, work on your project idea, and then create the abstract, and then we can submit it to a conference. Or if you want to write a an article, you can make it as a manuscript, submit it to a journal. So there is no limitation. So it depends on what you want to do. Most of the fellows were familiar with systematic review, and it can be done remotely. So everyone from home, they can do it. In the past, we had experience with collecting data from Sparrow Hospital here in Lansing for certain projects. This also can be done remotely. So we just ask them to get certain information from the chart. Because of the EMR, now the data can be collected and then sent in a format like a Excel sheet. So we can analyze the data out of that. In other studies, we went to nursing homes and collected some information from reports. So each nursing home, they have their own reports, but nationally here in the US, they have a report that's come like every month. So out of all these reports we collected during the pandemic, early pandemic, we compared what's happening before and after COVID. So we can do that also. So there is no limitation of the method. Good question. Any other questions? Any other comments? If not, then I know there is a team working on renal app, and also the dental group working on dental mobile app. So if anyone interested, maybe you can reach out to work with them and see if that can be completed soon. If you have questions, if you need any further instructions or guidance, the seniors will be happy to help. I know some of them might be unavailable because they plan to take steps like step 3, or they are involved in other things. But in general, most of them are very helpful. All right, I'd like to thank all the presenters from today's presentations. Great work. Thank you all. Thank you, Dr. Hajer, for moderating this Zoom meeting. Thank you for leading the team. And I'd like to thank all the present fellows. Thank you for sharing and attendance. And the new ones, thank you for joining the program. And those who will look at the recording later, thank you so much for watching this. Have a wonderful day. See you next week. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you.
Thank you so much, sir.
Thank you so much.
Thank you so much, sir.
You're welcome. Thank you.
Thank you, Dr. Nader. Thank you very much.
Thank you, Dr. Nader. Have a good day.
Thank you so much, Dr. Nader.
Thank you, Dr. Musalba. Good luck.
Thank you.
Have a wonderful day.